in the section of cardiology, the Central Hospital of Wuhan. In the initial of February 2020, she was in charge of the fever clinic during the COVID-19 outbreak, maintaining the medical procedure of operation and save the critical patients. So first, welcome Dr. Jen Chen give us the lecture.
No, Madam Huang, can we let us introduce these colleagues?
Well, I think we will just carry on because people are joining in. We have got with us colleagues from Salford Royal and also our Northern Care Alliance Hospitals consultants. They
Yes.
are, there would be well over 50 people, and we will not do any introduction, but when anyone is asking question, they will introduce themselves. Otherwise, we would spend a lot of time in just introduction. Okay? Thank you.
Great.
Thank you.
Yes, could we have Dr. Chen first?
Yes, okay. Please.
他有的话，
I think they are trying to make a PPT.
Okay, yes.
So, as you can
Can you see the screen?
Yes, it is on the
Hold on, you see the screen?
Yes.
Yeah, okay.
Can you, my colleague, friends from Salford, can you see this?
Yes, we can. We can.
Good.
You can?
Yes.
No?
We can.
Yeah, I see you. Okay.
Yes, thank you.
Thanks for introduction. Good morning, everyone. In China, the outbreak of COVID-19 began in late January this year. Our hospital was the earlier designated hospital specialized in the treatment of COVID-19 patients. And from that time, all the medical staff were reassigned to new positions. But during that period, I came to the fever clinic. Today, I would like to share with you some ideas and experiences in my work. First of all, I understand the main clinical characteristics of COVID-19 patients in China. In the context of pandemic, we should keep alert to patients with these symptoms. Fever is one of the common symptoms. Among the patients, 43.8% had fever, and nearly half of them had a moderate fever, and the other 40.8% had a low-grade fever. The cough, the most common symptom, and 67.8% of the patients had cough. The other two common symptoms were sputum production and fatigue, and each of the rate of occurrence was more than 30%. Beginning from late January, the patients with fever, cough, and other special symptoms were initially classified as the suspicious patients, all of whom had accepted further examination. Other effective experience in China is that the management outside the hospital was turned to the respective communities. The patients with fever and other suspicious symptoms would report to the communities actively, and the community commissioners are responsible for arranging them to the designated hospital for treatment. And it is not recommended to go to hospital by themselves. The advantage of this though is that you can have detailed information about the source of each infection. In the fever clinic, masks, masks, not necessarily surgical masks, were provided for all patients, including the accompanying personnel, because masks can reduce the spread of droplets and prevent the cross-infection. The procedure of fever clinic should be clear, and the dedicated personnel are arranged for triage. All patients need to carry out various nucleic acid detection, blood routine test, and lung CT examination. In outbreak period, extensive examination is very important. Once the condition is confirmed, such as confirmed or highly suspected cases, the patient should be arranged to isolation center or to be hospitalized as soon as possible. If the initial diagnosis is negative, the patient should be tested twice or more times, and the lung CT should be checked after 3 to 5 days. If the nucleic acid test is still negative, it is also recommended to isolate themselves at home for at least a few days until the symptoms disappear. During the isolation time, close contact with their families should be avoided. For those severe and critical severe patients, we need to identify them in time, arrange priority treatment and hospitalization as soon as possible, or even admission to ICU. In fever clinic, we tried to reduce the waiting time of all patients in the hospital. When the number of patients surged in early February, fever outpatient doctors were added accordingly. But at the same time, it's very important too. We should also try to reduce the continuous working time of medical staff to reduce our risks of infection. However, at the beginning, because of the serious shortage of healthcare workers and not fully understanding of the serious consequences of this virus infections, the continuous working time was up to 12 hours. With more healthcare workers joined the assistant team, the continuous working time was reduced to 6 hours, and finally 4 hours. Therefore, we emphasize that suspicious patients with the above symptoms need to see a doctor in time. The first important step is to do the nucleic acid test and the antibody test of COVID-19, both of which are highly effective diagnostic measures. Second important step is isolation. Once the diagnosis is confirmed, the isolation will be carried out immediately. But the previous experience in China shows that the isolation of patients at home is not reliable, which could cause family or community transmission. Later, special isolation places have been set up, including the shelter hospital. Now it seems that it is very effective to isolate the confirmed or highly suspected patients and equipped with professional medical staff for management, which can quickly cut off the source of infection. For general people, it is also very important to stay at home and stop socializing to reduce the risk of infection. Due to the limited resources of hospital beds, it's vital to implement the treatment in the fever clinic. For the patients waiting for beds in fever clinic, oxygen therapy will strive for more survival opportunities for them. We also need to find out which people need oxygen therapy in time. If there is no limitation for oxygen therapy device, oxygen therapy can be started for patients with blood oxygen saturation less than 93% in China. For the awaiting patients, if the condition is unstable or serious, observation rooms are set up, which are managed by dedicated doctors and nurses. It is key to identify those patients with rapid progress in time, but it's very difficult sometimes. When the nasopulmonary oxygen therapy is not enough to reduce and improve the symptoms, it is recommended to proactively give respiratory support treatment from nasal cannula to high flow oxygen therapy. And the timing of using the ventilator is suggested to be earlier than that for general respiratory failure patients. Regarding the antiviral treatment, Abidor intravenous ribavirin etc. are suggested to be taken based on China practices. It should be noted that these treatments are all empirical treatments at the early stage of the epidemic, and it is not recommended to use more than 3 antiviral drugs at the same time, and the course of the treatment should not exceed 10 days. In China, about 20% of patients with COVID-19 would progress to severe and critical severe patients. For those patients with respiratory failure requiring mechanical ventilation, shock, or other organ failure, they need to be admitted to ICU for monitoring and treatment. During the outbreak period, more medical staff, beds, and ICU wards are needed. Wuhan, located in the center of China, was the epicenter of the COVID-19 pandemic, with strong support from the whole country. The pandemic situation has been gradually contained, and the city is reopened and restarted today after 76 days lockdown. We also hope that global pandemic will be brought under control as soon as possible, and that everyone will remain healthy and return to the normal life. Okay, thank you.
Thank you very much. Is there any question? Can I ask, please identify your name and then ask question if anyone wish to.
Hello, good morning.
Yes.
Good morning.
Yeah, good morning. My name is Dr. Noel Bakley. I'm a chest physician from Salford. Can I ask you a question about the treatment you have used? You did talk about multiple regimens in terms of treating COVID-19. Did you find any difference in the treatment you used compared to the course of the disease? Have you tried to apply certain treatments at certain phase and other treatments at a later phase? Or did you apply the treatment based on the clinical presentation or any other factors?
Can I just explain? The question is regarding the treatment by any medication. When did you use the treatment? And what was the indication for treatment? And was there any difference in the group where you used the treatment? Is that clear? Is that question?
I think it's about if when the patient presented earlier, you've used a certain regimen, whilst in a patient who has more severe disease and presented later, you've used a different regimen?
陈主任听清楚没有？
Thank you for the question. And I'm Chen Juan's colleague, and I'm also in department of cardiology. And I also take into the front line of this battle in Wuhan. So I can ask you this question in my own experience. So your question is, what about medical therapy in treating the COVID-19 and in different types of patients? And as we know, our own guideline and classified this disease into the 4 types. It's classified into the mild one, the moderate, the critical, and the severe and the critical. So, to the different types of conditions, the medical medicine is also different, and also to the different phase of the disease, and also different methods. And as well, in the early phase of the disease, the support supply also like the oxygen therapy and the other food therapy is very important. And also the to the mild supply to a mild type of the patients, the quarantine or isolation at home is best therapy. If the patient has obvious symptoms such as a cough, such as a fever, such as the disease, the chest pain, and they can enter the designated hospital throughout the fever clinic. Yeah, and in the hospital, we can also use some of the therapy, the medicines and the traditional Chinese medical therapy, and the medicines such as the antiviral therapy is very important, such as the Abidol, such as the ribavirin, and others. Also, the alpha amphetamine is also can be used in the early phase. But I can for special pay attention to the glucocorticoid is not necessary in the early phase. It's very important, and because the non-proper use of the glucocorticoid may accelerate the conditions of the disease. And besides that, also we can have some oxygen therapy, such as the mask or the lethal use. And if the patient happen to the oxymeter, we can use the validator. But the validator can be not used easily if necessary.
So,
and besides that, we also have some traditional Chinese medical medicines.
We have heard about all these in various publications and all. What we would like to know, if from you, from your experience, that could you give us any advice that is any of these medicines, in your view, has been more effective? Is there a data to show that that is the case?
Yeah. As we know, there is no vaccine up to now. So, for the therapy to the COVID-19 as supportive. So there is no the very, very effective of the medicine. Indeed. Yeah.
But
and we should treat the patient according to the various manifestation.
Sorry, did you manage to collect any data which could show that one of these treatments that you have used, because you are the only one far enough to tell us that is any of these treatment has been better for your patient, or is anyone was with any negative consequences? Because we would like to know if that is possible with some reassurance that one of the medicines that you have used we can use with some degree of confidence. So if you have got any data, please share with us so that we could look at it and be able to use at either at the right point or if necessary early in the disease.
这个
Yeah.
我讲一下啊，这个张先生，就是咱们索尔福德这个医院的这个意思就是什么呢？在他这么多的给药中间，治疗方案中间，哪一种相对比较有效，你们用的比较好，让他们吸取一下经验。
阿比多尔是我们中国只能推荐的这件事。阿比多尔是。
As we know, antiviral therapy is more effective.
Okay.
Yeah.
Right. Well, we
And
understand.
I can also say that if not necessary, the ventilator cannot be used. It can increase the mortality. Yeah. According to some large scale, small scale of studies published in China and Europe. Yeah.
Okay. Thank you very much. Any other question? You know, we here don't encourage our patient to come to hospital if they have got fever or cough, but to isolate unless they have got bad symptoms. What's your comment on that type of policy?
这个没听懂。
他说就是一个症状来，政策的一些问题。As you know, China and the Western countries have a lot of strategies about treating this disease. And in our country, in the early phase of this disease, an outbreak of this disease, we also take this strategy, such as if there's not a serious symptom, you can stay at home for quarantine. If your symptom is very obvious, you can go to the hospital for isolation. Because of the lack of the bed in the early phase of this period. But until now, we have enough bed for treating everyone, so we can ensure to treat everybody, admit and treat.
Okay.
So this is the difference between China and other countries. And as well, UK is still a rising period of this COVID-19. So you can also meet the same question of lack of bed, lack of medical staff. So your choice will be very difficult. So I can also ask you for this question. Do you think the herd immunity work? Herd immunity work? This is my question, because we have a different strategy to treat this disease.
Yeah. Okay, that's fine. So if there is no further question, we could move to the next talk.
Can I ask a question?
Oh, yes,
this is
yes,
Dr.
of
Joel
course.
Paul
Sorry.
from Manchester.
Yeah. Go ahead.
So
镜头给那个提问的 Joe， 谁管镜头呢？
Okay. I think Dr. Chen and Dr. Liao has given us very excited
有
lecture.
一个问题，黄
Sorry,
总
we have a question.
给 Joe 要提问。Joe, can you ask your question?
Joe?
yes,
Okay.
can you hear me?
Yes.
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 Joe, what's Joe? Oh, yes.
Hi.
Question.
Can you hear me?
Yes.
Yes.
Okay.
We can start the chatting. Joe? Do you
Hi.
have some question? Joe? Hi, Joe. We can see
Yes,
you.
I have a question. Can you hear
Yes.
me?
Yes.
Yes, we can hear you.
Okay. So I'm a clinical virologist in Manchester.
Yes.
One of the slides said test, test, and test. So my question is,
Yes.
do you test everybody who gets admitted in the hospital, like an admission screening test, or do you only test if they have cough or fever or influenza-like illness? Thank you.
Yeah. I know your question. As you know, we have many designated hospital for the confirmed cases and the suspicious cases. So, if the patient with symptoms or the nuclear test is positive or the antibody positive, you can admit to the hospital. If there's someone have lots of obvious symptoms and only the positive for the nuclear test, so we call them the asymptomatic patient. To the symptomatic patient, we maybe the infection is not large, so we can take them for quarantine at designated locations for 2 weeks. Yeah.
So, do you have a
Thank you.
do you have
Yeah.
availability of test kit in plenty, or do you have a restriction on that?
Restriction on the
听明白没有？就测试的那个测试盒，测试那个剂是不是很多，还是不够要分配？
Yeah, sufficient.
Sufficient.
Yeah.
Do you also have got antibody test available now?
Yes, we have.
Yeah, we have.
And how long you have been using antibody test?
Maybe 1 month.
1 month.
Yeah.
1 month. Okay, maybe you could send that to us then. Okay.
Can we have the antibody test?
Last time maybe 2 or 3 hours. Yeah.
2 or 3 hours. Okay, I will have a chat with you later. Thank you very much. Okay, let's move to the next one.
Okay, next one. Next one is Dr. Xiaoman He. She is the nosocomial prevention department and come from the nosocomial prevention department and the public health department. And she will give us the topic about experience of prevention from hospital infection with COVID-19. Okay, please.
Thank you.
Well, I noticed all of them.
They all put nice.
So we need to ask this question.
They don't maintain this.
But it is working.
Yeah. All the time.
Yeah. Yeah, that's really important.
Morning, everyone. 请允许我用中文来解析这个防控工作的相关工作。我们请我们的王博士来辅助我完成这个我们之间的这个沟通。那么我们医院是在2019年12月底接诊了第一例的这个疑似患者之后，越来越多类似症状的患者涌到我们医院，那么主要集中在我们的急诊和呼吸科。此外， 其他的部门也说了，不分症状、不典型的患者，面对越来越多的患者，我们医务人员承受了很大的压力。The first case of coronavirus in our hospital was established in the end of December last year. Shortly after that, more and more patients with similar symptoms poured into a hospital, most of which is centered in ER and respiratory department. The situation overwhelmed the medical staff of ER and the respiratory department. Besides, typical patients also messed the doctors up. All medical staff were under great stress, facing torrents of patients flooding into hospital. 那么这是一个呼吸道系统的一个疾病，后来发现非常容易在人际中进行传播。那么我们流行病学的专家报道，也就是一个患者他是可以感染2到3个健康人，那么感染的病例可以在2到3天内这个纷纷的播散。This is a kind of respiratory illness, and it turns out to spread easily from person to person with high degree of mobility. Epidemiologists have reported that the virus can transfer from one patient to 2 to 3 healthy persons and infect them. Cases can double in 2 to 5 days. PPT 要调一下。没有，就是开始。那么这些都为医院感染控制带来了很大的一个难度。为了应付这些挑战，我们采取了一系列的防控措施。我们接下来分享的措施，我们认为还是非常有效的。Those all brought many difficulties for the prevention and control of nosocomial infection. To cope with that, we have taken a bundle of preventions and control measures, and we thought the following measures were really counts. 那么最重要的一点就是政府采取了很积极的一个应对的措施。疫情发生以后，武汉市是立即就封城，那么所有的居民是待在自己的家中，商场、学校、体育馆等等公共的场所均被关闭。那么这些强制性的措施也阻断了新冠状病毒在人群中的一个传播，延缓了病例上升和扩展的速度。First and foremost, in the fight against the coronavirus, the government had taken positive measures. Wuhan had been locked down immediately after the outbreak of this coronavirus, and all residents had to stay at home. Shopping malls, grocery stores, schools, and other places where people may gather together were all shut down. It's a mandatory order that could block the virus transmission among crowds and stop the case numbers from increasing. 那么此外，在短时间内，武汉市建立了方舱和隔离点，用于轻症患者的就诊和隔离，那么减轻了综合医院的这个压力。那么在10天以内的时间，建立了2个这个传染病的医院，将大型综合医院改造成为收治新型冠状病毒肺炎的定点医院。那么举全国之力，调集了几万名的医务人员来增援武汉。那么这还给武汉调拨了大量的防护用品和生活的物资。这些举措都避免了综合医院的医疗资源的挤兑和崩溃。Many function shelters and quarantine points had been constructed in a very short time. Mild infected patients could get medical support and be isolated there. That reduced the suppression of general hospitals. Meanwhile, 2 contagious disease hospitals were built in 10 days. Many general hospitals were remodeled to coronavirus designated hospital according to isolation requirement for contagious disease. Once, 然后thousands of medical personnel from all parts of the country were assembled in Wuhan to provide medical support. A large number of PPEs, medicines, and other important materials are provided to people in Wuhan. All those measures mentioned above relieved the pressure of general hospital greatly and prevented hospitals from collapse. 那
那么我们医院也实施了一系列的防控措施。首先，我们是设置了专门的隔离病区来收治确诊和疑似的患者。那么隔离病区的布局和工作流程均满足我们国家的消毒的，均符合我们国家的隔离消毒技术相关的一些要求和规范。隔离病区分为3区2个通道，以及增设了2个缓冲区。那么在清洁区、潜在污染区和污染区之间，3区之间还有加上了2个缓冲区。那么医务人员和患者的通道是分开的，其他无关人员是不能接近隔离病区的。
In our hospital, a number of prevention and control measures were taken. First of all, coronavirus confirmed patients and suspected patients were resettled in isolation departments. Observing strict isolation strategies, the isolation departments were remodeled according to the isolation requirements for contagious disease. The workflow met the relevant requirement of the hospital isolation technical regulations. The isolation departments were separated into 3 quarters, namely clean area, semi-contamination area, and contamination area. 2 buffer rooms were set up to separate the 3 areas.
那么隔离病区不同的区域有特定的一个防护的标准。那么隔离病区每个工作人员在进出病区的时候都必须严格按照要求穿脱防护用品。那么此外，缓冲区有专门的感染防控技术人员进行督导，一方面对医务人员穿脱防护用品进行督导，另一方面对防止污染区的物品回流进入的清洁区进行一个监督。
Professional staff and patients had a different separate passage in case of cross infection. Other people unrelated are strictly limited access to isolation wards. Specific guards for different areas were essential for efficient isolation. Every healthcare worker was strictly requested to wear and take off isolation garments properly when they entered and left the department. Infection prevention and control technicians were assigned to prevent items from contaminated area being brought into clean areas, and to supervise the medical personnel on putting on and removing protective equipment so as to prevent contamination.
那么适宜的个人防护用品对于这个院感的防控十分的重要。那么疫情初期的时候，我们制定了适合于我们医院的一个穿脱的防护用品的一些流程。那么隔离病区医护人员要戴这个医用的防护口罩、防护服、一次性的医用帽、一次性的手套、防护眼镜和一次性的防水靴套。此外，医务人员在给患者插管、做手术、操作一些高风险操作的时候，需要加戴一些正压的头套。
Adequate personal protective equipment is essential for preventing nosocomial infection. We made guidance on wearing and removing personal protective equipment. At first, every staff working in isolation wards should wear medical protective masks, medical protective garments, disposable surgical cap, disposable gloves, goggles, disposable waterproof boots. Particularly, doctors and nurses should wear positive pressure ventilation protective hood during the performance of intubation operation.
那么所有的这个隔离病区的医务人员在上岗之前都需要经过防护用品穿脱的培训。此外，一线的工作人员需要进行每日的健康的监测，鼓励他们尽量居住在相对独立的一个隔离区域。如果工作人员有新冠相关的一些症状，而立马对其进行隔离，并完善其相关的检查。那么一线工作人员在工作2到4周以后，会进行2周的一个轮休，以保证其这个身体的状况的保持一个良好的健康的状况。
Before working in the isolation ward, every professional staff had to take the training of how to put on and remove personal protective equipment. Health monitoring and health status record should be conducted for all frontline staff. Medical staffs were encouraged to live in an isolation accommodation. If a staff had any relative symptoms such as fever, they would be isolated immediately and screened with other tests.
After working in isolation ward for 2 to 4 weeks, professional staff would have 2 weeks quarantine to get enough rest between shifts and assure their good health condition. 根据各种规范和指南，我们也出台了自己这个隔离病区的清洁消毒的要求，包括环境物表、空气、患者的排泄物、血液、体液、分泌物等等清洁消毒的一些要求。那么所有病区每天要进行清洁消毒2到3次，整个消毒过程要保证足够的消毒时间和适宜的这个消毒剂的一些浓度。According to guidelines and regulations, we have published the disinfection procedure for coronavirus isolation department, including disinfection of environment, objective surface, air, fecal matter, and spills of patients' blood and fluids. All isolation wards were carried out disinfection 2 or 3 times a day, and repeated the procedure at any time in case of contamination. Make sure that disinfection time is enough and the concentration of chemical disinfectant is suitable. 在隔离病区当中的疑似患者要单间隔离，那么确诊患者可以放置在一个房间，房间距至少是1.2米。那么每个病房都配置有足够的设施，包括卫生间等等。患者活动要局限在病房以内，是禁止探视和陪护的，减少不必要的一些诊疗活动。那么鼓励患者通过电子设备与亲朋好友进行联系，对患者进行咳嗽礼仪、戴口罩、戴外科口罩、舍卫生、居家隔离等，进行一个健康的宣教。Suspected patients were isolated in separated single rooms. Coronavirus confirmed patients can be arranged in the same room with bed spacing of no less than 1.2 meters. Each room should be equipped with facilities such as private bathroom, and the patient's activities were confirmed to the isolation ward. Family visits were forbidden and nursing shall be declined. Patients are encouraged to communicate with their family members and friends by electronic devices. To prevent further spread of coronavirus, patients were educated and instructed on how to wear surgical masks, proper hand washing, take the COVID-equipped medical observation, and home quarantine. 对隔离病区的工作人员的行为要进行一个督导，要求做好手卫生，要避免高风险行为的一些发生。All frontline staff were supervised by infection prevention and control technicians to comply with hand hygiene and to avoid high-risk behaviors. 那么上述提到的一些防控措施，有效保护了我们的医务人员，也阻止了医院感染的发生。我们的经验表明，通过积极有效和严格的一些措施，隔离病区的医务人员是可以得到有效的这个保护。All the measures mentioned above have effectively prevented our medical staff from coronavirus. Our experience indicated that healthcare workers on the isolation ward could be effectively protected from contracting by taking efficient and strictly observed protective measures. 好，发言就这些，谢谢。Thank you.
Thank you very much. Is that?
Did you just ask them if they can hear you?
Can you hear me?
Rashid?
Yes.
Any question?
Can you hear me? So yes, there is before we go to that, there's a clarification about the question on testing. Could we get some answer
We'll get to this, yeah.
Yes.
Can you adjust your camera angle, and we cannot see you?
You can't see me?
Just say
That's it. That's it.
Okay.
yeah, using mine.
Okay. So what it is that a question on testing is any patient who is coming to contact with the medical profession getting tested, or
hello, is that North Manchester General Hospital?
Sorry?
Can you put me through to the surgical registrar on court, please?
Oh, sorry.
Thank you.
Paddy, can you mute your mic, please? So, is every patient who came in contact with the medical profession got tested, or only those who had symptom?
有症状还要干嘛？喊人。
听清楚了吗？问题
要听清楚。
没有听清楚啊。
Peter 高，这问题没有听清楚。
Okay, can you repeat your question slowly?
So, it's about testing for coronavirus. Oh.
Yeah, test, 检测。
Is every patient who came to the hospital tested, or only patient who had symptoms?
听清楚没有？
几个病人还是几个医生？
对，他问题是我给你重复一下，问题是什么呢？是不是对住院的所有病人都进行这方面的检测，还是只是对有症状的临床症状的检测？
对，在那个疫情来说，在整个疫情过程当中呢，我们主要是针对有这种疑似患者的，我们会进行一个排查，就相关的一些检查来进行排查。可能这个排查的这个要求会这个范围更加扩大一些。
The patients will sit with the relative symptoms. We'll do the test.
Only symptoms.
常规的这个要范围要放得宽一点。然后整个门诊进来的话，是要经过整个的预检分，那么经过一层层的排查，前期是排查和疫情期间。
Sorry, do we have?
是这个意思吗？还是说所有出现症状的患者，应该是出现所有。
那个。
但现在这时候的进来不是说。
So hello. So in our hospital, during the epidemic,
can we mute everybody else's mic? We have got lots of noise coming.
Okay, thank you. So in our hospital, nearly all the patients who came to our outpatient will have a series of tests. If the patient has the symptoms of fever, cough, diarrhea, fatigue, or something like which think they are suspicious patients, so we will give them the test.
Okay.
And also during the epidemic time, in the last 2 months, the majority of patients with the other diseases, they do not really choose to come to the hospital. They will stay at home. So only the patient who have some troubles or some symptoms, they will come to our hospital. So actually, I think the answer should be nearly all the patients who came to the outpatient will receive the test.
Okay. Now, can I a supplementary question on the same thing? That patients, did you do any operation in your hospital during the this epidemic period?
Okay. Okay, and so during the epidemic time in our hospital, the majority of the surgery was emergent surgery.
Do you have any
elective
data?
Surgery is very, very less.
Okay, elective. What happened to the cancer surgery? Cancer patient?
Cancer surgery.
Yes.
Okay, I think our Dr. Du will answer the question in the later section because he will present his experience later.
Okay. Now, one question on this isolation in the hospital, different area. in the hospital, do you have did you have the separation of staffs between two area, or the staffs were going from one to other area by taking precautions?
Pardon? By taking what?
Taking precaution by changing their PPP, or there were different staffs.
You mean separate the medical staff by what?
Yes,
I didn't
medical
hear that
staffs.
clearly.
Medical staffs were same for the isolation area and other part of the hospital.
Isolation. Excuse me, do you mean that our medical staff, so did they be isolated in hospital or in the other area?
No. My question is that the medical staffs were same for the isolation area and the rest of the part of the, or they were different teams?
Different teams.
Yes, it's true. So the medical staff will, when they change their area to one to another, so they will change their clothes and also the protective things.
Okay. Thank you. Is there any other question?
Can I ask a question?
Khurshid, Zola McFarlane here.
Yeah.
I don't know if you can hear me. In the clean areas in the hospital, so if not an isolation ward, not an area where there's any suspected COVID patients, what PPE would staff wear in those areas in the hospital, if any?
清洁区的没有那个新冠那个病人的区域内的医务人员穿戴什么样的防护用品？有没有人回答？就是医务人员在非新冠区正常的。
Okay, so in the clean area, so our medical staff just wear the cap, surgical cap, and surgical mask, and the lab coat like what I'm right now.
Right. Okay. Thank you.
Is there any other question on this topic? Yeah, we will be next. Okay, thank you very much. We could this all very informative for us. So we will let's move to the next speaker. If you
next one. 第三个专题。
The third speaker is Dr. Hu, come from respiratory and critical care medicine department. Okay.
Okay. Good to see everybody. I come from Wuhan. My main topic is about the normal patient about COVID-19. The severe and critical patient will talked by Dr. Wang. In my hospital, the main patient is the symptom is about fever and a dry cough or progressive asthma. Some patient will become perhaps it's below the ARDS, and the other symptoms include diarrhea, fatigue, or the chest tightness. And most of the people about the age above the 19 years old, and the main patient are more vulnerable, and the old age, obesity, and if the patient have the chronic disease might be associated with include mortality. As we know, we will very it's important thing is clinical history. As Professor Penn, he tell us that the second and the third week from the illness on site is a critical period. It's about 15 to 20 percent of all the people at this period will become and increasing into the severe or critical patient. And the third laboratory test in most patient is white blood cell will decrease and the foresight will decrease.
The upper lady's plus the eye itself is quite
LDH,
should we ask you for the antiviral ointment as well as the antiviral?
Sorry, we have got lots
inflammatory
of
factories. Example,
those who are not speaking, can you put yourself on
the
mute?
IL-6.
2 weeks, 5 times a day.
Can we have, we have got lots of noise coming. Can you switch off your mics, please? Okay.
And okay.
Yeah.
Laboratory test and the chest radiological imaging should be close emotioned, and we should get the nose or throat swab, sputum, no respiratory tract or blood or stool is positive for SARS-CoV-2. And the chest radiology, and this is a common case from January 19th to January 31st. First is the ground glass opaquity. It become the area is more, and after our treating, it's most of them is observed. And the third patient is a man. From this patient, at the first day we can see a GGO at the red lobe, and the third day the area is increasing. We give them antivirals and antibiotics and give some low dose of corticosteroid for about 5 days, and as well as supportive treatment. And after that, the 15 days, is most of the GGO is disappeared. And the third one is a severe case. It's a female. It's about 76 years old. This patient, and at first, it's just as most of the low lab is at the GGO, and after about 2 weeks, it's perhaps its patient, its area is continue to increase, and so we give him the high flow oxygen. And the CT exam, we should, as we check the time for CT re-examination is about 5 or 6 times. First time is about the number the third of 5 days, and the third exam is about at the 7th or 10 days, and if the third or fourth examination depends on the patient's condition. And we also give the patient some bronchoscopy. As we found from the bronchoscopy, we can see have nothing in the trachea or the bronchs. It's very, as we say, it's very dry. As our initial classification, the mild case is about without the pneumonia. The common cases is about a fever, respiratory symptom, and in our radiologic map is have pneumonia. But as we know, it's very important that special focus on the second and the third week is about 15 to 20% of patients will progress to severe case or critical case during this period. And the severe case is about respiratory distress, especially his respiratory rate is all about above the 30. This is, I think, the respiratory rate is very easy and very important parameter. And the oxygen index is about below 300, and about 50 programs in chest radiology imaging within 24 or 48 hours. And the critical ill cases is all about respiratory failure, is need marginal ventilation, and all they have shock or multiple organ fault. So this patient must be transferred to ICU. And at this period, we should do with the different technology. It's about that knowing variants of pneumonia or bacterial pneumonia, and the other non-infectious disease. So it's very important to us. But it's very dangerous to us that at this period, we don't find the other variants of pneumonia. It's very strange to us. The main treatment plan is about the patient. We ask the patient rest in bed, monitor vital signs, supportive treatment, and maintain internal homeostasis. And we should check the monitor blood routine, organ function, and inflammatory factor, blood gas analyze, and so on. And we check something within 3 to 6 days for mild case, and 2 or 3 days for several cases. And the very important, the critical case, we must check again in 1 or 2 days. And oxygen treat is very necessary. As we know, antiviral treatment is about several drugs or the other treatment. But to my opinion, no one is a winner. To my opinion, there is the biggest or the best drug to treat with the COVID-19. And the antibiological street, we should avoid planned or impartial use these drugs. Treatment for several critical illness. The main is relieve symptoms, prevent and treat complications, and treat comorbidities, prevent secondary infections, and timely multiple organ support therapy.
Wuhan.
And especially we should I think it's very important to this pyramid. It's about the continuous decrease lymphocyte count, and especially the market node count of the B lymphocyte. It's about there are especially decreased number of CD4 cell and CD8 T cell, and increasing and the market increased inflammatory factors, especially that IL-6 or CRP, or the other pyramids. We say again, the respiratory rate is about 30. I think it's very easy to observe, and it is very important. It is very important to the patient. Most of the severe or the critical patient, the respiratory rate is very fast and more fast. Tell us that the patient is will become the better, the best, worse. And I think cortisol treat is very important in the COVID-19. It's indication about rapid progress in chest radiologic imaging or SP is below the 93% at rest without oxygen. The other one is respiratory disease is about above 30, or the oxygen rate is below the 300. There is a clinical case. This is a 39 male. He is with fever and cough is about 6 days. From the 26th January, he has a diabetes. From his chest imaging, it is shown pneumonia. His respiratory tell us that at the first 3 days, his respiratory rate is more and more higher. And after our treat, his respiratory rate is become lower, and the it's about 1 month. 1 month after 1 month, his respiratory rate is become normal, and his white blood cell and lymphocyte from the so we can see that at the first 3 or 5 days, his lymphocyte is become lower, and after our treat, their lymphocyte is become above the 1 set. The other is LDH. It also tells us that if the LDH is very high, some of them is tell us the patient could become the severe or critical. After our treatment, the patient LDH is become lower. And there is from the blood gas analysis, we choose the oxygen is become low at the first 3 days. After our give some oxygen treatment, the patient's oxygen is become higher. Imagine we can see at the first, the patient, the area of inflect is very located, and after 3 days, the area of his is become the too low, and his breath is very is too fast. It's about 10 days. The area is become, and after our treat, the area is become decreased. It tell us give some treatment. The all is give some messy presi 这是啥 prednisona. At the first 2 days, we give it 40 and Q12 hours. After 2 days, his respiratory failure is become higher. So we change our prednisona at Q8 hours. After 2 days, his symptom is become better. So we decrease the dose of the prednisona, and it become it treated at from the 26th January 26 to February 8, and the other treat is about ritonavir. It's from the first day to it's about 15 days, and the other is about antibiotics to treat, but it's just only 3 days. But I think the other important treatment is about high frequency nasal oxygen. It's from the 3 days to it's about continue. It's about 2 weeks. So, in this patient, our experience is about timely judgment, treat of materials, and the other important treatment is persistent oxygen treat and high frequency nasal treat when necessary, and the other therapy. So this is the magic of our doing the bronchoscopy. And this is our college. They are our heroes. And this is the team. They are the great team. So that's all for today. Thank you.
Oh, hello. Thank you very much. Very, very sobering and informative talk for us. Any question? Is there any question, please?
This is Noah Baker again from Salford. Can I ask a couple of questions, please?
Please, yes, go ahead.
Thank you very much. That's really, really informative. I have 3 questions, please. The first one is, have you noticed any relationship between ongoing pyrexia and prognosis? We know that there are certain biomarkers, CRP, LDH, troponin, liver function that have been entertained as being associated with outcome. Have we noticed any relationship between ongoing temperature or pyrexia and prognosis? So that's my first question. My second question is, out of those who deteriorate at week 2 and 3, do we know the proportion of those who end up in intensive care? So those who deteriorate around week 2 to 3, the proportion of them who end in intensive care. And my last question is, do we have mortality figures from intensive care from your data?
So there were 3 questions. The first question, if I repeat, is any correlation with temperature, pyrexia, and outcome. Is that right?
That's correct.
Yeah. Is our colleague in Wuhan, have they got this question?
Wuhan 那边听明白没有？
没太明白。发烧与什么？
We have to.
Can we first, Kashif, can we first give the photo, the camera to the doctor?
Can we? Well.
So that's sorry. That's me asking the question.
Yeah. Are you on the screen? They want
relationship between ongoing pyrexia and prognosis.
Yeah. It's about 15 to 20%. 15， 我刚才写了一张。15
to 20%。
他第一个问题问的是什么？发热与什么的关系啊？
Can you, doctor, can you rephrase your question and they can understand it?
Okay. So did we notice that those who ended up in either having poor prognosis or ICU had more difficult to control temperature? What I mean is that they've been having ongoing pyrexia more than other patients.
Have they? So if I put that question in the reverse way, those patients who needed to go to intensive care, did they have difficult temperature control or they had higher temperature? I don't know if they would actually understand that question.
明白没有？就是体温方面的问题。
这个体温还不是说特别有高热的。Fever is not.
I don't know if they will actually get that. Should we ask?
No.
他说的是，他问的是在 ICU 里面发热的病人多不多？
是吧？
就在 ICU 里面的病人体温是不是很高？他们体温是不是很高？
I think the fever is not important with the severe or the critical patient. In my opinion, in ICU, most of the patient is not don't have the high fever. Wait a minute. Dr. Wang will tell us something about the treatment in the ICU. He will tell us detail.
Yes, I understand.
In ICU, okay?
Okay.
The next speaker is from ICU.
No, but the question
will focus on more detail regarding this question.
But there is a simple thing which you, because we are not able to communicate, but what we asking is patients who have had high temperature early, high temperature, pyrexia early.
No.
Did they get worse outcome?
I think the high temperature is a symptom of the COVID-19 patients, but not all the patients of high temperature need to go to the ICU. We should know the patients, if the patient has the symptoms of the dyspnea and low oxygen, the oxygenation index is lower than 200 or 100. We should send him to the ICU, intensive unit care. But the temperature is not the only symptom.
Okay.
And we also found some people with high temperature in the ICU. It's really hard. It's a really harsh tough to control.
Okay. What was the second question then?
The second question is about the proportion of patients who end up in ICU out of those who deteriorate at week 2 and week 3. So, for example, a patient develops COVID symptoms. At week 2, they start to deteriorate. What's the proportion of those who deteriorate at week 2 and 3 end up in ICU? As if I've heard something like 15 to 20%.
我跟你概括一下啊，就是说这个确诊了那个 COVID-19 病人在2-3周以后进入 ICU 的比例有多少？他说我听到了一个15%或者20%，对不对
？Yeah.
把它放上去吧。
在上面我打共享了呀。
也许可以
他看得见呢。
Can you see
second and third 15 to 20%?
Yeah, I can see 15 to 20%. So I'm assuming those are the ones who ended up in ICU. Do we have mortality in ICU? Mortality figures? How many of those the proportion of those who ended up in ICU died?
Yes, I sent that question as well.
那等一会儿Dr. Wang 来说吧。
你能不能这样？就是你现在这个能不能呢？就是你知不知道？就是关于这个咱们说是进了 ICU 以后的话，咱们就说是这个。
我刚才不是说了吗？等一会儿那个我们那个 Dr. Wang 他会来介绍 ICU 的情况，以及最后的那个可能那个转归的情况，他可能会说一些。我刚才说了，我这边主要是介绍以轻症的 the normal case is.
And Dr. Wang from ICU will, that's his area, and he will talk in more.
Okay, so that we'll get more information on that after the next talk. So that's all
Thank
right.
you very much.
Yeah, should we just move to the next talk then?
OK， 接下来我们有 ICU 的我们的王主任王主任。好吗？我们开始下一个好吗？下一个专题。
Okay, so the fourth talk, Severe Patient by Dr. Yujing Wang. Yes.
Do we have Dr. Wang?
Attending physician in ICU from the Wuhan Central Hospital.
Thank you.
I'm honored to present this presentation to you. Next, I will share our experience about the treatment of critically ill patients with COVID-19 with you. In December 2019, a novel coronavirus disease caused by SARS coronavirus 2 infection broke out in Wuhan and spread rapidly throughout China. As of March 31, 2020, the World Health Organization reported more than 1 million COVID-19 cases have been confirmed in at least 200 countries, and more than 60,000 people died from the COVID-19. This picture shows the epidemiology of COVID-19 in our hospital. With the outbreak of COVID-19, the Wuhan municipal government has issued a series of policies, including the closure of the South China Seafood Market, lockdown of Wuhan City, the establishment of designated hospitals, temporary cabin hospitals, and the construction of 2 hospitals which are specific infectious hospitals. The number of patients reached a peak at the end of January and then gradually decreased. From this chart, we can also see that most patients died in February. A couple of factors probably caused a high mortality among the COVID-19 patients in Wuhan at early stage include the sudden emergency of a large number of patients. Most hospitals here have problems with oxygen supply. Most of wards are not suitable for infectious disease, and the lack of medical personnel and materials. Epidemiological study in China show that the overall mortality rate of COVID-19 patients was 2.3, and the mortality rate of critically ill patients was 49%, even as high as 60% in the early stage in Wuhan. This is a single-centered retrospective observational study. 52 critically ill adult patients with SARS coronavirus 2 pneumonia admitted to the intensive care unit were included. From this chart, we can see that the mortality of critically ill patients with COVID-19 is 61.5%, and the median duration from the ICU admission to death was 7 days in the non-survivors. Analysis of 109 COVID-19 patients from our hospital in early stage showed that mortality rate of COVID-19.
Yeah, I'm off today. Yeah.
Sorry, can other people mute their
It's
mic,
of
please?
on admission in the early days, on admission was nearly 50%.
Sorry?
Therefore, treatment of critically ill
Can I
COVID-19 patients.
remind you who are not, asking this? Can you just silence
Which one?
your microphone?
Is there any
Yeah. No, it's actually Well, it's not ventilated. It's not on ventilation. Well,
Please, someone's mic is on and we can hear you talking. Please.
Nasim Saidi, please turn your microphone off. Nasim Saidi, please turn your microphone off.
Okay.
And for anyone else who's got their microphone on, please turn it off so that our team in China can do the presentation.
Okay, I will go on. So the treatment of critically ill COVID-19 patients is of great challenge. How to reduce the mortality rate of critically ill patients with COVID-19? I will share a case report with critically ill patients with you. 42-year-old male was admitted to our hospital on January 21, 2020. He had initial symptom of fever. The maximum temperature was 38.8 centigrade. His cough and fatigue. No dyspnea, no chest pain, no abdominal pain, and unconsciousness disorder. We could see raised leukocytes and decreased lymphocyte and platelets. The renal function, the liver function, and the coagulation seemed normal on the first day admitted to hospital. On January the 22nd, the chest CT showed a few patches, but on the January the 13th, 8 days later, the chest CT re-examination revealed progression of the lesion, and a throat swab sample confirmed that the patient had a COVID-19. Given the serious shortness of breath and the deleterious hypoxemia, he was transferred to ICU on February 4th and was given invasive ventilation on February 8th. The medication from day 1 to day 12 included antiviral therapy, anti-inflammatory and immune modulating drugs, antibiotics, and also include anticoagulation therapy. Even after intubation, the patient was under progressive deterioration. He was diagnosed with AKI and severe ALDS. We used the lung protective ventilatory strategy, prone position ventilation, and deep sedation, but the hypoxemia was not resolved very well. So on the day of the intubation, we initiated the VV ECMO on the patient. And after a period of 6 days usage, we assessed the patient condition and weaned the ECMO from the patient. But the patient was not stable. The oxygenation deteriorated again. We had to initiate VV ECMO once again on February the 28th. From this slide, we can see that the sputum culture revealed Candida albicans on the February 13th, and carbapenem-resistant Klebsiella pneumonia on the February the 17th, and Acinetobacter pneumoniae on February the 25th. So we escalated antibiotic strategy, which combined different antibiotics and antifungals according to the cultural results. This slide showed the input and output and the urine between the day 13 to day 36. We also applied the CRT to keep homeostasis and fluid balance. This chart shows the dynamic changes of laboratory findings between the day 13 to day 36. We re-examined the chest CT on February the 16th and February the 22nd. It didn't show any improvement on the images. As the sepsis were progressing, we worried about the non-infection and catheter-related bloodstream infection. The patient had been oral trachea intubated for 23 days. So he underwent tracheotomy on March the 4th. Cause of the need for anticoagulation during ECMO and coagulopathy, the blood oozed around the tracheotomy wound. We frequently changed the wound in dressing and sutured the wound to stop the bleeding. The oral ulcers were also seen because of long duration of oral trachea intubation. We also restored central venous catheter and used PICC instead. We used the fiber bronchoscope to suction airway secretion and keep the airway open. The bacteria culture from the secretion of lower respiratory tract was done daily. Repeated 2019 coronavirus nucleic acid tests were negative. We selected antibiotics according to the results of the bacteria culture. And the indicators of infection gradually improved. You can see from the chart. We reduced the dosage of sedative and analgesics, try to keep the patient with light sedation. As the respiratory function improved, the patient successfully weaned from the mechanical ventilation on March 13th and switched to high-flow nasal cannula. The patient would keep awake during ECMO. And last, the patient was successfully weaned from ECMO on March 16th. The dynamic lab results showed improvement from this chart. And the CT scan between the March 6th and the March 13th showed multiple ground glass shadow in both lungs are observed. Early rehabilitation may help the patient to improve the quality of life. Until now, the patient is still hospitalized and getting better day by day. Our experience and apply effective respiratory support promptly include the nasal catheter, oxygen mask, high-flow nasal cannula, mechanical ventilation, and even ECMO. Non-invasive ventilation is effective, but do not delay invasive ventilation. When the patient is still breathing with difficulty and has high respiratory rate during using the high-flow nasal cannula or BiPAP, recovery of respiratory function may lead a long period. We should use long protective ventilatory strategies from position ventilation for severe areas. Fiber bronchoscope is helpful to keep the lung open and to avoid airway obstruction. We should carefully assess the indication for initiating and wheeling the ECMO. Sepsis is common among critically ill COVID-19 patients. Prevention of nosocomial infection is very important. Closely hemodynamic monitoring is essential. Fluid overload is harmful to critically ill patients. Renal replacement therapy and blood purification treatment to keep fluid balance, to keep the electrolyte balance and clear inflammatory cytokines. Early rehabilitation is helpful to prevent ICU-acquired weakness and to improve the quality of life. That's all. Thank you for listening.
Thank you very much.
I don't think they can hear you.
Can you hear me?
Could you switch on your microphone?
Yeah. Can you hear me?
Yeah, I can hear.
Hello. Thank you very much, Dr. Wong, for an excellent talk and giving us a example of a very difficult case. Have you got information of how many patients you actually used ECMO? How many patients you ended up using ECMO?
In our hospital,
yes,
the total number of the patients were applied ECMO is 5.
And are you in a position to say that, I know it could be difficult, but that was it beneficial, or was it in those patients the outcome was better?
Sorry?
那问题是那个 ECMO 对这个5个病人有帮助吗？是不是使用了以后结果会更好？就是结果就是产生的好的结果。
We found in the lung region from we recover for a long time. So the ECMO on these patients will last for as long as 50 days. So only the invasive ventilation is not enough. And the patient for lung ventilation will result in the ventilatory induced lung injury. We also found bad trauma in this patient.
Okay.
So I think ECMO is the rescue therapy for these severe ALS patients.
So I'm sure there would be more questions, and let's ask if anyone else has got any question. We will be asked for the next, because that's the surgery.
Can I ask a question?
Yes.
Peter?
Yeah, thank you.
So my question is, unfortunately, based on resources, there is a big ethical dilemma about ceiling of care. Did colleagues in Wuhan have similar problem? When do we say that we have tried the maximum? Peter, can you let them know, please?
Yes, yes. 这个问题是什么呢？这个问题是一个，就是说我们说就是像我们讲什么呢？这是道义上的问题吧？就是医疗资源到什么程度，还有没有这样的问题？不能用了，就没有救了，或者你们有没有这样一个考虑到一个就放弃治疗了，又要有一个选择了，有没有这个方面这样一个道德上的这样一个伦理上的一个考虑？
Yeah. The number of ECMO machines in Wuhan is limited. So not every severe ALS patient could be applied with the ECMO or even the intubation. So if the patient with the elderly patient with a lot of comorbidity or the severity of the patient.
Yes, of course, we understand it's a very difficult situation and you have to decide on case basis.
Kashid, we cannot hear you, Kashid.
Could you hear me?
Yeah. So we do understand that it is difficult to deal with these difficult patients, and you probably take multiple analysis to decide which treatment to offer. And question was that was ever resource was an issue, but it may be that we won't get an answer for that.
Yeah.
So is there any other question?
Yes, there are plenty of questions on the group chat. 武汉医生，武汉医院的医生们，大家请看一看，主任们哈，您看看在那个群的聊那块儿已经有大概4个问题，是英文的，然后我翻译完了，大家可以看一下，然后回答吗？ So there are questions in the group chat which I've translated. So if I'm just waiting on Wuhan doctors to respond.
Yeah.
Okay.
好，我先把我们这儿的麦关掉啊。
这儿呢。
Already 4 questions before this question, so I would like to answer the 4 questions first. So first question is which group of patients underwent CT chest and what value did it add? So nearly in our hospital, almost all the patients underwent CT chest when they came to the outpatient, because we find also a huge number of people. They are the COVID-19 carrier. They carry the virus, but they do not have any symptoms. But they have some change in the CT graph. So this is what we have found. So we did also the medical staff in our hospital. So a number of staff, they do not have symptoms, but they underwent CT, and we find there are also the ground glass change in the lung. This is the first question. And the second question, was there a different level of PPE during the emergent abdominal surgery or orthopedic surgery where there is drilling of bone? So for this surgery, so we have the highest level of PPE. I think
so
the doctor have already showed that in one of the slides. So all the doctors, the surgeons who did this surgery, they will wear disposable surgical cap, medical protective mask is an N95, and work uniform, disposable medical protective uniform, disposable latex gloves, and also full face respiratory protective device or powered air purifying respirator.
Okay.
So this is the second question.
Was there any difference between the different procedures, like orthopedic or intestinal? Why is in theater, in the operation theater, was there any difference between different procedure, like if it is an orthopedic or bone procedure or a gastrointestinal procedure?
我们做的那个手术，
做了手术吗？做了，有5个吧，好像5台吧，跟你们。 对，杜主任做过舞台，
Yeah,
等一下会分享。
Rashid, your question is related by the next speaker.
做过没有？
Okay.
So during the epidemic in our hospital, there are 5 surgeries related to abdominal surgery have been done during this time. And later on, Dr. Du will share the experience with us.
Okay.
And for the surgery during this time, we didn't do any orthopedic surgery.
Okay.
So no this kind of experience.
Okay.
And the next question is which healthcare staff members would we test and when? So since February, so in our hospital, we have set up some strategy for our medical staff. So each medical staff who are working in the hospital at that time will have the opportunity to undergo CT chest test and nucleic acid test. And for the medical staff who will stay at home, so before they came back for work in April or in March, they were allowed to have the CT test and nucleic acid test. And for the medical staff who have been infected by the virus in February or in January, so after more than 2 weeks recover time and quarantine time, they will receive the CT test, nuclear test, and even antibody test before they come back.
Okay.
And the last question, do you use lung ultrasonography? Actually, we have the ultrasonography for lung, but in the epidemic time for COVID-19, we use CT, computer tomography for almost the patient, because in our hospital, we have more than 4 machines for CT, so this is enough for our patient. And also the CT was running for 24 hours without any stop. So we thought that the CT is more sensitive and with higher resolution for detecting the change in the lung. So we didn't use the ultrasonography for lung. And any question?
Okay. Are we going to move to the next paper now?
Okay. I will try to answer the next question. And in my ICU, the patient were intubated for a long time. So we advise if you think the ventilation will last more than 2 weeks, you should try to do the early tracheotomy. And the tracheotomy will help you to make to reduce the need of sedation and analgesia, and it will make the patient will more awake and to exercise his respiratory function. And it is facilitate to the suction of the trachea secretion.
Okay.
Next question is about the coagulation. In the critically ill patient, we found that the dimer were almost very high. And when the D-dimer is above the 1 microgram per liter, we will give the patient with the anticoagulation. And the most medication is the low molecular weight heparin for preventive.
Okay. I think it would be better if we move to the next paper and then answer all the questions.
Yes, yes.
Is that all right?
Yeah, 我们接下来进行最后一个吧。我们请那个杜医生、杜主任。
杜主任。
Okay, 可是the final speaker.
Yeah. So Dr. Hang Shong is going to
Dr.
talk.
Hanson, your old friends.
Yes.
And this time is Dr. Jian Guoshi, your friends.
Old friend as well.
They will give us the topic of diagnosis and treatment experience of emergency patients of gastrointestinal surgery during epidemic prevention and control of COVID-19. And they have done maybe 5 operations during this pandemic program time. Okay, welcome.
I'll mute you.
Yeah.
Hello, everyone. Hello, Professor Akada.
Hello.
I'm Jian Guoshi from the Department of GI Surgery, the Central Hospital of Wuhan. And you can call me Dr. Shi. On behalf of my boss, Professor Hansong Du, I will address some experience in the diagnosis and treatment of emergency patients of GI surgery during the prevention and control of COVID-19. COVID-19, that is the official name for the virus that has now affected the whole world. According to the WHO notification of the outbreak as of 5 April. As shown on this slide, the United States has the highest number of cases, yet the country with the highest number of deaths is Italy. Both number of confirmed cases and deaths, Britain ranks high over the world. The COVID-19 outbreak is still full of a lot of uncertainty in the world. In China now, most of the confirmed new cases are imported. This is easier to control than earlier outbreak in Wuhan. I want to talk about something else here. I've been working in the hospital or staying indoors after work in Wuhan through the entire epidemic. During this time, everyone in China has been doing something called social distancing. People in China have totally changed their lives, changed their mindset, changed their living habits. In order to prevent the spread of this virus, it's an incredible thing to witness even as a Chinese. Social distancing and face masks for all. The whole nation has been waiting. Amazing absolutely amazing. Okay, this is a mobile cabin hospital converted from Wuhan Stadium. Our country has almost built 13 cabin hospitals and 2 new hospitals. Huosenshan Hospital and Leishanshan Hospital. Suspected cases with mild syndrome symptoms were transported from the community to the cabin hospital for observation and basic treatment. Only confirmed cases were admitted to the Huosenshan Hospital and the Leishanshan Hospital and the other designated hospitals. According to BBC News, London's patients in need of intensive care, but with the best chance of survival, will be taken to the Nightingale Hospital, an intensive care hospital with 4,000 beds. The hospital will be the biggest intensive care unit in the world. There will be one in the Manchester. Although I'm a gastrointestinal surgeon, I still need to be familiar with the COVID-19 related policies, diagnosis and treatment programs, and the prevention and control measures of nosocomial infection. The government has organized the experts to develop kinds of treatment plans for COVID-19, which are constantly updated. Some experts have formulated certain consensus or suggestions based on the characteristics of their own specialties. COVID-19 attacks alveolar epithelial cells through SC2 receptor expressed in alveolar epithelial cells and initiates an inflammatory response that leads to the development and progression of interstitial pneumonia. COVID-19 can also bind to SC2 receptor expressed in mucosal epithelial cells of the digestive tract and affect the function of the digestive system. Therefore, patients with the novel coronavirus pneumonia may have gastrointestinal symptoms, which are mainly manifested as poor appetite, nausea, vomit, abdominal pain, and diarrhea. Some patients even have gastrointestinal symptoms as the main or the first manifestation. The following study shows that approximately 48% of COVID-19 patients have digestive symptoms. Some of these patients require emergency treatment for the gastrointestinal surgeon. We will face special challenges in special times. The gastrointestinal surgery is an important branch of the general surgery with many diseases and complicated conditions. The common emergency diseases of GI surgery, including acute appendicitis, gastrointestinal obstruction caused by a tumor or non-tumor, gastrointestinal perforation, persistent gastrointestinal hemorrhage, and apparent abdominal pain with unknown cause. The surgical treatment of gastrointestinal surgery, the recovery time of post-operative lung function was prolonged due to general anesthesia, ventilator-assisted ventilation, and post-operative supine on the bed, especially in the case of systemic protection. Our surgical field of vision is not very clear, and the operation will be slow, so the operation time is longer than usual. Most of our patients had abdominal infections, which, combined with the impact of surgery, made the prognosis of NCP patients worse. We still need to differentiate with the acute abnormality of internal medicine, obstetric and gynecology, and consult if necessary. This picture shows the scene of operation for a patient with chronic tumor obstruction. We conducted a right hemicolectomy plus ileostomy. When we conduct operation, some suggestions may help. Comprehensive equal gentle operation to avoid iatrogenic injury. So far as possible to shorten the operating time to reduce the risk of exposure. It's recommended to avoid the use of electric knife during the operation for patients with COVID-19. That could reduce the generation of aerosol and reduce the risk of infection of medical staff. Because three-level protective measures can reduce the visual, auditory, and tactile functions of medical staff and affect the operation. It is recommended to use iodine or hand sanitizer or anti-fogging paper towel and other hydrophobic liquid to smear the goggles or wear a comprehensive respiratory protective device or a positive pressure head cover to maintain a clear intraoperative vision. We often sweat when we operate in a level 3 protective condition, and sometimes it's like being caught in the rain. So be careful not to get a cold after the operation. We operated 5 emergency, maybe 6 emergency surgery during the outbreak. A laparoscopic appendectomy and an opening, 2 gastric perforation repair operations, incision and drainage of large perianal abscesses, a right hemicolectomy plus ileostomy. That's all, and hopefully the world will soon get better.
Is it just the bullet cases or
Thanks.
just over there? Yes, because it's not clear.
Hello. Yeah, thank you very much. Thank you. Obviously, we have lots of concern about surgery during COVID period. So we have several questions with you. So these 5 patients, they were COVID positive.
问题听懂没有？那5位受的你说这个是不是那个新冠病人
No, only one person, only one patient.
So
was confirmed after the surgery.
So what my next question is that was you not receiving other emergency patients, because we have lots of emergency patients in our hospital, and in last few days we would have done 5-6 cases. So what has been happening in Wuhan?
问题，武汉这个期间呢，有没有其他的急诊病人？现在在索尔福德呢，就其他的这个是肠胃的急诊病人也还在收，他每天还在最近一段时间又做了5、6个床手术。你们武汉那边情况怎么样？是不是这个期间就不收其他急诊病人？
our hospital is the designated hospital of COVID-19.
Okay.
The patients and there are the other hospitals will
do those cases. I understand that.
Diversion is diverted, yes.
Okay. So did in Wuhan, was there some hospitals who were COVID negative, no COVID patients? Is that?
Yes.
Okay. So was that managed centrally?
是不是由政府控制的？中央控制的，就是哪些医院呢有这个新冠，医院没有，是由这个咱们政府来整个统一协调的，是吗？
Yes.
Okay. And so any patient, cancer patient who needed an operation, did they go to COVID negative hospital and not to your hospital?
其他病人，比如说癌症病人的一些治疗，是不是到了一些非新冠的医院去治疗，还是在你们医院继续治疗？
No, they were transferred to the other hospital.
COVID negative hospitals. Okay.
COVID negative.
And before the operation, when a patient is confirmed COVID, he or she will be transmitted to the designated hospital. But some case we can't confirm the case before operation. So we also operate some patient after surgery confirm COVID.
Okay. So so what would be your recommendation for us that we have patients in our hospital who need operating, and we have got large number of COVID patient. What should we do? Should we transfer them to other hospital? Yes.
问题明白没有？他说索尔福德医院有很多新冠的病人在医院了，同时呢，他还有很多呢需要治疗的其他的病人。你们的建议是什么？
Just protect yourself and wear the protection unit, such as protection equipment such as goggles and level 3 protection.
Yes. So you would say that we should continue operating with level 3 protection.
是不是你们说有3级保护，继续治疗，对吧？
对。
确实要治疗，要3级防护。如果
Correct, yes, level 3。
多等的就是
in your hospital, did you maintain a COVID negative area?
在你们医院有没有新冠，就是非新冠病区有没有？
有啊，有南京路是在一起。
可是 they have two sides, remember?
We have two area, and one is designated to be severely and one for normal.
Okay.
Question about the mortality.
There was a question about mortality in patients with after operation, a COVID positive or in a hospital mortality after operation. Is there any data on risk to a patient after our operation during COVID period?
这个问题就问一下手术的这个就是失败率，就是手术的死亡率。因为在这段时间呢，咱们这个新冠这段时间呢，手术呢这个增加了一些这个就是非常特殊时期。他问一下有没有这方面的数据，就是说是在这个期间做手术的死亡率有什么影响？
The mortality.
柳叶刀看到一篇文章，你做手术的死亡率20%，阳性的做手术死亡率20%。这个文章是不是？
In our hospital, the mortality is 0 because we only we just operate we just operate six emergency operations.
Okay.
Do they swab them routinely or?
So
can I have a question, please?
Yes.
Yes.
Thank you, Peter. You might have to translate this for our colleagues in Wuhan.
Yes.
Can you hear me, Peter?
Yes.
Thank you.
Yep.
So from the 1st of April, China is reporting the data as symptomatic and asymptomatic positive COVID cases.
Yeah.
To my surprise, it was published on BMJ on the 2nd of April. They're currently saying that nearly 80% of the cases which are confirmed COVID positive by laboratory test do not have symptoms. So they are asymptomatic. Now, which changes everything with our COVID-free hospitals, emergency surgeries, planned surgeries, and other plans that we're doing.
Yes.
My concern is that we know that nosocomial transmission is very well explained, and the vulnerable post-operative and other immune suppressed patients who are in these COVID-free hospitals might be exposed to a virus and cause severe illness.
Yes.
So inadvertently, without our knowledge, this is new data coming out from China, which will have a high impact on other countries because most of our plans are around COVID versus non-COVID zones, essentially.
Yes.
So we're trying to separate in a big way and see whether we can keep the patients who are not COVID positive. But my concern from new data emerging that nearly 80% can be asymptomatic and transmitting, which changes the whole concept of how we are managing globally of having COVID positive wards or hospitals and COVID negative ones.
Yes. 这个问题比较，他说了很多，实际上是什么意思呢？也就是说呢，中国4月1号开始呢，对这个所谓的无症状的这个病毒的携带者开始发布信息了，是吧？咱们说这4月2号呢就出来一些数据了，说这要引起全球的一些警觉，或对全球的一些预防措施要产生很大的影响。因为这些没有症状的携带者呢，会对我们的所谓原来的提到的非这个新冠病区或者医院或者这种情况，或者是社区传染，会产生一些很重大的影响。他就提出这样的问题。
我们目前回答，你跟他回答，就跟他说，我们是这样的，就是我们把所有的患者就当成潜在的感染者，做指标级别，
全民筛查，
级别不能随意降低，级别是没有降低的，就在近2个月之内都不会降低防护级别。
你们谁来回答一句？
正在回答。
Okay, I will answer the question. So we all know that there are a symptom people who are carrier for the virus. So right now in our hospital, we still took the the third level of protection in our outpatient and also the inpatient department. And for the all the population in Wuhan, so the government also takes some strategy for detection to detecting the nucleic acid for the people who go out for work, for school, or for outpatient. So and also the test of the nucleic acid is much faster than before, so it will be much easier for us to test those people who are carrier for the virus, because we also know that it is very important if those people who are carrier, they just go outside and eating and also gathering with each other, so it's quite dangerous for other people and also dangerous for the all the medical staff and hospital. So in our city, we have already taken the strategy to test in the people who are out in the public. So they have the possibility to go to the public and go to work or go to the hospital. So they are forbidden. They are mandatory to take the test.
And where do they get these tests? How do they get these?
In hospital.
So
in every hospital.
So the people have been asked to go to the hospital to get tested.
Yes, if the people want to go back for work.
Okay.
Or for school.
Okay.
Yes, they have to show the certificate, show the result for nucleic acid.
We should all have
if
that.
it is negative, it is allowed to go for work. If it is positive, it has to be quarantined.
Thank you. That's very useful because
that's
I think
excellent.
going forward, we will have to think about that in a big strategy.
Yeah.
I think many countries, including UK, are setting up large factories trying to test people in large numbers, and that will be the one which will determine the spread or stopping of this virus. So I think we are all following the principles of lockdown, social distancing for now, but we have to get those factories up and running to get more and more testing like Wuhan. So looks like the trick is to try and test as much as we can. So somebody put a nice slide saying test, and that seems to be the right way to do this. The only problem is I don't know how fast we will be able to do it or whether we have the time, but we are trying. Thank you so much.
This is Bala. Can I ask a question?
Yes, Bala, go on.
Yeah. Here we are in the midst of the epidemic and none of us are wearing masks. You have declared Wuhan is free and you are all wearing masks. Regarding the masks, do you wear it all the time? Whether you are in a clinical area, non-clinical area, going outside the hospital? And what do you do to prevent taking the infection from the hospital back to your own homes?
这个问题给你翻译一下，说是现在呢，我注意到呢，你们都在戴口罩呢，医院里的戴呀，这个病房里也戴呀，回家路上也戴。好了，问题是如何预防将医院的这种污染或者是病菌带回家？
No, we're not doing it.
不是，他是说你戴了口罩上了班，比如像我们办公人员，你回去怎么样？
不是你这个不是，说你口罩一直不好。
Okay, so I would like to answer this question. So yes, we wear mask all the time, except being at home. So we have the mask on the way to the hospital and back home.
我跟你讲啊，我跟你讲，他们为什么问这个问题呢？因为在英国有个说法，你戴口罩，那个相反，口罩会把一些病毒呢，因为你口罩顶上有病毒啊、病菌呐，带回家。所以他说你一直戴着口罩，那么医院和家里或者在路上都是这样戴，你有没有考虑怎么样预防把病菌从医院带回家呢？
Yes, so we will change the mask before we return back home, and also we do a lot of hand and hygiene with the disinfected fluid.
Well, I have, in solidarity with you, I have put my mask on as well.
Yes. Okay, please.
So, sorry, there is
Not
a question.
not all of us have masks, Dr. Khurshid.
我说呀，我们这儿很多人都没口罩。
What was that?
Not all of us have masks, unfortunately. We are waiting for somebody to mass produce masks as well.
We need some masks from China to be sent here. I think this we are coming to the nearly end of our time now. So thank you very much for all friends in Wuhan, especially our the people who I know personally, and my sincere thanks to all friends and colleagues in Wuhan. Our last year visit, Salford Group's visit, was excellent. We really enjoyed. We didn't know what's coming behind us, but the way you have dealt with this problem, you have given us some good information and some ways to tackle it in our place. So thank you very much.
And we need the video and disseminate
So
Can I thank Dr. Khurshid and Peter for organizing this? It has been the best 2 hours in the last 1 month for me. I learned so much in 2 hours. Thank you so much, Peter and Dr. Khurshid.
Okay, thank you, and thank you for everybody for your participation.
And also there is a request for the video.
Excuse me?
There is a request
I
for
noticed that there's also one question which has not been answered.
Okay,
but
please
we
go on.
I think it is very important.
Yeah.
I think the question is that did all the patients were kept in isolation wards? Yes. And also we have the semi-contaminated area, buffer area. So maybe you are interested in the role of this area. So for us, the semi-contaminated area is between clean area and contaminated area. So this area is mostly for the medical staff. So they have to work sometimes there, for example, to work with computer for the medicament, and work for the drugs, to prepare the drugs, prepare for the liquid. So this area still has the possibility to be contaminated by the patient. So we call it semi-contaminated area.
Okay.
And there are 2 buffer zones between the 3 areas. So this buffer zone, we use it for take off the protective lens or put on the protective lens, depends on which direction we want to go. For example, if we go from contaminated area to the semi-contaminated area, we will take off one layer of the protective suit, and also the mask and the surgical cap. And after we go back from the semi-contaminated area to the contaminated area, we will put on a new one. So the buffer area almost is for the change the protective lawn. And also we have a specific staff there who just give us the introduction and instruction to teach all the medical staff how to take off, how to put on, and we have several steps which are printed on the wall. So each step is very clear. So it will reduce the possibility for the medical staff to make any mistakes for contamination. So we thought that this kind of zone will be much safer than just have one buffer and clean and contaminated area. So we think it's very good management for the zone.
Yes, I think everybody would agree with me that you have organized the thing in a very scientific way, and I'm not surprised that your results have come and you got the benefit of reward for that. I think we can learn from that a lot, and hopefully we will be able to get some of those things implemented in our hospital. So I would say that we should now conclude the meeting, if that's all right.
Yes, Kashid?
Yeah.
Kashid, can we have Kevin just before we finish, we have Kevin.
Oh, yes.
Who also, is the driving force behind this. Kevin? Yes.
Kevin and Bo, if they want to say anything.
Yeah, just final, yeah. Okay.
黄主任，你跟他们说，如果有问题。
行，我说两句啊，那个这次呢，感谢我们这个武汉中心医院，和我们黄家草根医院，我们两家医院的这个领导专家以及一线的医护人员，感谢你们对这次这个新冠病毒共抗疫的付出奉献。我代表我们英国医疗教育中心对你们表示崇高的敬意，这个衷心感谢你们辛苦了。
谢谢刘主席，谢谢刘主席，谢谢刘主席和这个英国方面给我们的大力援助，还给我们带来的援助物资。然后我们今天是非常高兴能有这样一个机会跟大家连线。虽然就是这对我们武汉来说也是一个很突然的一个非常的一个巨大的灾难性的一个疾病，一个烈性传染病。但是我们也是第一次碰到这样的情况。然后我们2个院区吧，一个院区呢就是一个感染性疾病收治院区，就是我们上次带 Kersher 去看的那个后湖院区，还有高老师，那个是我们的专门收治感染性疾病的。然后我们的南京院区就是我们上次开会的那个地方，这个院区呢就是我们的非新冠病人收治院区。所以当时呢，我们也是非常艰难的度过了这3个月，然后也得到了就是来自各方的很大力的援助，然后政府的力量也是非常强大的。我觉得这次就像我们王晨院士所说的，就是我们这次抗击新冠更多的靠的是政府的组织，然后科技的含量还是不如西方的发达国家。这是我们很比较中立的来看待这个问题。后面的话还有很多困难。武汉虽然复工了，虽然已经封城结束了，但是就像你们说的，我们有很可能会潜在的一些这些无症状感染者，所以对我们医院来说，我们不会随意的降低这个防护级别，病人要收，那些慢性病人、癌症的病人。那些病人要收，但是我们后面就是要做的工作还是任重道远的，也还是有很多，因为这些东西都是以前没有经历过的，对我们来说也是一个考验，很不容易。也要谢谢大家，我们的经验也非常有限，我们也向你们多学习。
好，谢谢。我们看看这边有些医院也有很多医院联系到我们，有些要是分享的，还得麻烦你们一起在咱们的这个经验，大家共一起讨论这种分享一下，好吧？
Yes, thank you, Kersher. Thank you.
Well, thank you very much. Convey my.
If you have some questions, you can send it send email to nurse, and we'll try our best to answer all of these questions for you.
Thank you very much. It has been an excellent
opportunity. Take care. You look so tired.
We will hopefully we will all be able to conquer this condition, and then you can come to Manchester.
Yes, I think you will get better soon. You will get better soon.
Hopefully. Okay, then. Convey my regards to Secretary Chai and President Liu.
Okay.
Over and out.
回到来过